Powerful anti-COVID drugs that could keep people out of intensive care are sitting on the shelves all across the country, so let's explore why. I'm Lee Kelso from the HealthCall Live Radio Hour. The drugs we're talking about here are similar to what was given to President Trump, drugs he called a miracle. They're designed to keep COVID in check, to keep it from progressing and putting people into already crowded hospitals. So why isn't it being used? Well, let's talk with Brian Owens, a freelance science reporter and author, about that. He's been looking into it. Brian, can you tell me what's going on out there with this?
Well, the monoclonal antibody drugs were developed as a way of kind of stopping the progression of the disease. So these are ones that are used in people who are not hospitalized. The emergency authorization actually doesn't allow them to be used on hospitalized patients. It's for people who have particular comorbidities or just things that make them more vulnerable to a severe case of COVID. So for example, people who are older, people who are obese, people with diabetes might be good candidates for these drugs. And it's given to try and keep them out of the hospital and allow them to recuperate at home. But the problem is that it's a bit harder to treat people at home with something like COVID because they are, told to self-isolate. They don't go into the hospital unless they really need to. So it can be a bit tricky to actually give them these drugs in the fairly short window that they have to be effective.
Yeah, so these monoclonal antibodies are given by IV, and they're kind of like the vaccine in that they target the spike protein. So it's the key in the lock theory. They're designed to gum up the works and keep the virus from attaching itself more deeply to your cells and keep it from multiplying and spreading. So I get it that an IV is not something you're going to do at home necessarily, although you could. Home IV services are available. You could also do IV infusions in, cancer clinics do it all the time. What's the holdup here? Why can't we seem to get these off the shelf?
Well, it is that the problem of kind of where to do it. So at home, can be done at home. CVS is actually offering a pilot project in about 7 cities in their areas to do home infusions. They have a home infusion branch to CVS that will do this, and they're trying it out. A lot of other hospitals are setting up infusion clinics. There are, standalone infusion clinics for cancer patients. The antibody treatments are used in cancer treatment quite a lot. But the problem you run into there is that it's a little tricky getting patients in. So if you're going into, say, a standalone cancer clinic, you don't really want to be mixing people who are on cancer drugs, which tends to leave them immunocompromised, with people who are highly infectious with COVID-19. So you need to come up with ways to separate them either physically or in time and have lots of cleaning in between. And that's just kind of another layer of difficulty for getting the treatment at the right time. The other issue is that, a lot of people, when they get their diagnosis, they're not getting it in a hospital or even in a doctor's office. They get a phone call or a text message, or they check a web portal because they've been to a testing site and they're told, yes, you're infected, and they get some instructions on, isolating and maybe, contact your doctor. So they don't necessarily know if they should be getting these drugs. They may not even know they're available. If they have a doctor, their doctor may get notified that a patient has been diagnosed, and then they might think whether that person is a good candidate for this, but then the doctor might not know where to send them. They might not know where the local infusion clinics that are doing this are. And plus, lots of people just don't have their own GP. So they don't really have anyone to contact or anyone to tell them that, yes, this is a drug that's available for you and you'd be a good candidate for it.
So I take away from that if I am COVID positive and in a high-risk category with those comorbidities or advanced stage, that kind of thing, if my doctor doesn't tell me about monoclonal antibody therapies, I should be asking the question, right?
Yeah, that would probably be a good idea. Once you know that these are available, and if you think you're a good candidate, it's definitely something that you should ask your doctor about. The federal government in the US has bought millions of doses of these, but something like 80% of them haven't been given out yet. They're being sent out to the states every week based on however big the COVID burden is. The states then decide which healthcare facilities get them as they trickle out. But it's up to doctors really to prescribe them. The nice thing is that because the federal government has paid for them, it's all free, or at least the dosing is free, because these drugs can be very expensive. but you do have to know that they exist and know how to get them in order for them to have the most effect.
This seems like a huge hole in the process here. I mean, I understand we're all focused on getting the vaccine out and getting as many people vaccinated as possible. But if it's going to keep people from going into the hospital and that disease progressing, where's the holdup here in getting physicians educated and all of us up to speed?
Well, it's that last mile problem that you have with a lot of interventions. It's, the researchers have come up with these. They've been tested, they've gone through clinical trials. But then this happens a lot in healthcare. There is this gap where, especially for things that are not being given to, if someone's in an ICU or in a hospital bed, it's always an issue to make sure that doctors know about it, to make sure they know how to prescribe it, to make sure they know how to bill for it, how to bill Medicare or insurance for it. Although the drugs are free, the infusion time and it takes an hour to infuse someone, and then they usually have to sit for about another hour or so to make sure they're okay. They haven't had any reactions, things like that. So all that kind of adds to the difficulty, as a lot of doctors might not know how to do this, and there is also some concern that it's an emergency authorization, so they don't have the same amount of evidence that they would normally have when they're deciding whether to use a therapy. They have this kind of early stage results, which show it's been quite good in certain populations, but some doctors might simply be waiting until they have more or stronger evidence.
Yeah, I'm glad you came to that. I was going to ask about that. So President Trump's experience was certainly positive. How effective are these things? And it sounds like we're kind of talking the same story about convalescent plasma therapy as well. It's not widely used, even though there's some evidence that it can work. Is there evidence this is more effective than convalescent plasma?
Yeah, it appears to be more effective than the plasma. At least because it's much more tailored to what exactly you're trying to target. So these drugs target the spike protein. They block the virus from then getting into the cells. In the convalescent plasma has a similar sort of thing, but you're then relying on kind of the natural antibodies that are floating around in someone who's been infected in their blood. So it's much more targeted to do it this way. But yeah, they've showed quite a lot of effect in the right kinds of populations. So the people who are have a mild to moderate case of COVID, but are at a risk of moving on to more severe and being hospitalized. And the evidence is pretty good. I could see why some doctors might want to wait a bit, but basically, for the patient populations that it's given this emergency authorization for, it is very good evidence that it's at least going to reduce their risk of getting very sick.
So is it your understanding that most major medical centers, hospitals are going to have this available to them? Is it a situation of small town hospitals, it's just not there yet? I'm just kind of dumbfounded that if it's that effective, it's not in use.
Yeah, it's not clear yet how, if that's one of the difficulties. That was one of the difficulties that was anticipated, that, big, rich hospitals in large cities that are in affluent areas are more likely to have the space, the expertise. They might already have a cancer clinic that can do these IV infusions, whereas a smaller local hospital in a rural area might not. And it really comes down to the states themselves. So the federal government, the Department of Health and Human Services, is sending these out to state departments of health and human services. And then the states have to decide which hospitals, which infusion clinics or whatever get whatever portion of these drugs that they've been given. And it's possible that they are giving them to the ones who are just able to pick it up much more quickly. And that would tend to mean larger hospital centers that already have infusion clinics and things like that.
In the experts that you spoke with, what's your sense? Are they frustrated by this? Is there an urgency about it, or is it just they're kind of just swallowing and moving on with all the other headaches we have around this pandemic?
Yeah, I think it's it's one among many sort of issues that have come up with treatment, with vaccines, and so I think a lot of the experts or a lot of doctors don't have a lot of bandwidth to sort of worry about everything that's going too slowly or not going according to plan. So they'd certainly, most people I spoke to actually are people who work in hospitals and do have access to this. So they didn't actually have a great idea of, what this holdup was in other areas. But they certainly were hoping that, word would get out and it would become much more common and used, because it's a way of protecting the healthcare system itself. If you can prevent more people from going into hospital, then you have more beds available for the people that really do get very sick.
Yeah, I think that's the role that we're going to play here, those of us in the media, right? We're going to inform those people who are in those high-risk groups that this is an option. And I think people need to be more of an advocate for themselves and ask those questions. Hey, is this available? Would this help me? And kind of push and prod a little bit if you're in that situation.
Yeah, for sure. Especially if you are, if your doctor has a large practice and you think that, they might get a notification that you've been had a positive test, but, if they have a large practice, they might be getting hundreds of those notifications every day or every week. And they just don't have time to kind of go through and say, oh yeah, this person who I see once a year or once every couple of years actually maybe should be getting these drugs. So if you've been diagnosed with COVID and you're older, you're obese, you have any of the kind of comorbidities that are known to make it more dangerous, it would be a really good idea, especially early on, to very quickly contact your doctor. One of the things about these is they appear to work best if they're given before your own immune system has really kicked in. So that really means within the first few days is when they're the most effective at preventing you from getting really sick.
All right. I think we'll leave it there. Brian, thank you very much. Brian Owens is a freelance science reporter and author. Glad you joined us today.
Thank you.